Good day, listeners. Today is July 2nd, 2025, and this is Vivek Babaria, a member of the Public Outreach Committee of the North American Spine Society and a physiatrist in Newport Beach, California. I would like to welcome everyone to the next installment of our podcast series showcasing interesting articles from Spine Line, NASA's membership magazine. Today, we will be discussing the article by David Gendelberg, Michael Coscia, and Ashraf El Naga, entitled An Innovative Approach to Spine Trauma Care in Low and Middle Income Countries, in the May and June issue of this 2025 year. You will have the pleasure of hearing directly from the authors, Drs. Gendelberg and Coscia. Our hope and goal is that this discussion will further expound on their compelling article and incredible work they're doing throughout the world. A quick reminder that Spineline is a digital-only article and newspaper with a fresh and exciting new format. To read all these articles and all its features, please visit us at spinelinemag.spine.org. Without further ado, I'd like to introduce Dr. Mike Coscia and Dr. David Gendelberg. Thank you so much for taking out such precious time away from surgery and joining us on this podcast.
Thank you for having us.
Thank you for this opportunity.
Both of you, please give an introduction of who you are, and we go from there.
Yeah, I'm Mike Coscia. I'm the director of Spine Care. This is a pilot program within the Sign Fracture Care organization. Sign Fracture Care has been an international nonprofit organization for 26 years that is involved in 60 countries around the world that are low and middle income. And our primary goal is the care, education, and empowerment of surgeons around the world in lower and middle income situations.
Hi, my name's David Gendelberg. I'm an assistant professor of orthopedic surgery at the University of California, San Francisco. Me and my team collaborate on a bunch of global health initiatives, particularly with Sign Spine, where I'm part of the Sign Spine team to help make the world a better place and provide good spine care.
Fantastic. And that's a great segue into my first question for you two. What inspired the transition or expansion of Sign from being just long bone fracture care to spine trauma in these low to middle income countries?
David, would you like to start on that?
Well, I mean, I think from a kind of my standpoint, it's we are very lucky to live in the United States, where we have a lot of resources and are able to afford and provide a lot of advanced care. However, there are places in the world that just don't have as much access to care and implants the way we do, and I think it's our duty to help wherever we can, and whether it be by education, resources, training, implants. I think at the end of the day, we're all human, and I just want to help do more good.
I think just also, if I could add in to David's thoughts, when Sign Fracture Care first began, we addressed long bone fractures in countries where the patients were very poor and didn't have access to care. And once this became a successful program and we started to spread to additional countries, we spread and actually began doing, in addition to upper extremity and lower extremity, in other words, arm and leg fractures, started to do more complex pelvic fractures. But the physicians and patients in the poor countries were requesting from the very beginning that we try to address spine trauma. Well, the organization's been functioning for 26 years, but spine trauma is just such a complex entity to try to address that it's taken up until 6 years ago for us to actually organize and try to address this in an organized fashion. So we're in 60 different countries, over 450 hospitals around the world taking care of extremity and pelvic fractures, but we're just now really getting involved with spine trauma itself.
Yeah, and the amount of success that Sign has had throughout the world with the long bone implants and orthopedic fracture care really puts them in a perfect position to expand towards spine care as well.
In those first few years, can you describe some of the early barriers that you had to address specifically when it came to making that transition? I know obviously it's more complex types of surgeries, but any other considerations or barriers you had to overcome?
I think one of the biggest issues is, first of all, understanding the systems and helping where we could help, and also knowing the limitations, because on the one hand, we want to expand care, but we also want it to be practical for the practice environment.
I think to add to what David is describing, when we did the long bone fractures through the initial organization, we actually developed the engineers with Sign Fracture Care developed implants, that is the rods and screw and plate systems that did not require any power equipment to place these, nor any x-rays to be able to use those in the operating theater. So it was a system that was made for the low and middle income countries. So as David's implying, the difficulty with spine surgery is that you have to have a certain level of capabilities. You have to have intraoperative X-ray capabilities. You need to have, in our day, CT scanners and MRI scanners to reach a level of proficiency that's actually going to be safe for the patients. So in order to do this, we really had to be very, very careful. And when we began picking sites and partners to work with that had these baseline capabilities to start off.
And that leads to another question that I have. Obviously, with the amount of technology that we have in this country, and every time I come to NAS, the amount of navigation systems that are giving us their demonstrations on the stage and their panels, having the skill to then also apply just basic ability to put a screw or in a pedicle without that type of guidance, it seems like the question I want to ask is the fellows or the people learning, how are they transcending the practical skills of working in these LMICs and bringing that back to stateside?
Well, I should say that one of the priorities, again, for the Sign Spine program is to train these surgeons to a top level. So we do sponsor fellows, and these fellowships are in Canada. These are presently at Western University and McMaster University in Canada, and they will start this next year at University of Toronto also. So the surgeons spend 1 year doing a full active fellowship there, gain their skill sets, and then they take those skill sets back with them to their countries. Now, one other technique that we've used and we've partnered with the neurosurgery group at Cornell, Dr. Roger Hartle and his entity at our program in Dar es Salaam, Tanzania, where both the orthopedic program from UCSF that David's a part of, as well as the neurosurgeons from Cornell go and give educational programs at the facility. So it's an in-house teaching type program. So there are different ways to educate the surgeons, but we put that as one of our top priorities.
Fantastic. And speaking of priorities, education, and research, in your paper, there's reference to REDCap as a backbone of the research infrastructure. What kind of data are you guys able to collect, and how do you envision this shaping the future of spine trauma care in these LMICs?
So on the red cap, we are assessing kind of the injury mechanism, imaging, exam on presentation, comorbidities, then then what surgery they underwent, how they did, what length of stay, time to surgery, and whatnot. And really, some of the difficulty that we've had has been with follow-up because like take a country like Tanzania, it's quite large, and we're working with the largest public hospital in the country, but there are some patients who live hundreds of miles away, and it's not always entirely easy to be able to commute that distance. So it also kind of puts us in a situation where we've had to develop creative ways to follow up, whether it's by video or by phone, and to try and kind of get those outcomes. And by measuring these outcomes, um, we're able to compare it to historical data and see how what kind of impact our education and implants have been having on patient outcomes.
Actually, if I could add to what David's clarifying, that is, one of our big focuses is to try to have a minimum of 1 year follow-up on all of our patients who've undergone treatment, both non-operative and surgical treatment, because that's one of the things that is really lacking in the international literature as to how these patients do in the low and middle income countries after they've had successful spinal surgery. And so the questions that certainly would arise is how does a patient go back into their society if they do have a partial neurological deficit? Are they able to still integrate back into the society? And how do the economics of that affect the patient, the patient's family, and the society? So in our REDCap database, we're trying to be very broad in looking at this both from a social aspect as well as the clinical and radiographic aspects. But the 1 year follow-up, we're putting a top priority on. Our organization is giving research grants to each of the facilities that we work with so that they can have a strong research team to try their best to follow up with the patients.
It seems like to be able to deploy such a broad and endeavorous and altruistic program, you need very strategic global partnerships and philanthropy. Your collaboration with the AO Alliance, UCSF, Cornell definitely brings this academic muscle to the mission. What does it take to build these kinds of sustainable and high trust partnerships, especially with countries?
I think a lot of it is communication, kind of reliability, but honestly, at this point, for instance, I've been to Tanzania a few times and I've met the surgeons over there, and I could honestly say that we've developed friendships. We keep in touch, even they will text me in the middle of the night with questions about cases that they have. Um, and it's really building a big community. We also have monthly um, both meetings where we go over cases, but also on the planning side, we have monthly meetings to kind of give updates on how we're doing, and we have the different sites that are participating together on that phone call to kind of talk about the progress, bring up concerns if there are concerns, as well as celebrate accomplishments. So, like most any other project, I'd say communication has been kind of the key.
If I can continue with what David's saying, is it's absolutely imperative to have face-to-face interactions with the surgeons to develop that initial trust to begin with. So our surgeons do go and visit these sites so that we can have a lot of mutual interactions. Sign also sponsors an annual conference, and Sign will supplement the travel expenses for the surgeons to come once a year, present their data, present the work that they're doing. And then during the course of a year, we, as David's clarifying, will work on WhatsApp to discuss individual cases as they occur. Also, we'll have monthly conferences. And then we do have the ability to interact with the x-rays themselves to review the cases in both a virtual sense as well as, again, over the telephone. So we try to have a continuous course of communication that's allows for comfort on both sides.
To be involved in something so amazing, how can individual spine surgeons, whether in private practice or academia, get involved with Sign's spine care mission?
I mean,
Well,
I would say before being added with a mission, Science Spine has an annual course in Richland, Washington every year. And I think that could be a good opportunity to kind of get to know sign, as well as many surgeons from around the world come and fly into it. And by going to the annual sign meeting, I would say that would be the ideal way to start the relationship with Sign Spine. What do you think, Mike?
Well, first off, sign is we're always happy to have any philanthropic donations. So funding it is a major aspect, as you can imagine, since this is it's a volunteer organization with no government support. So that always funding is a component. But I would certainly agree with David. Our international headquarters that's in Richland, Washington, is where we have the annual meeting once a year, typically in September. But that's also where our manufacturing facility is. So for all the long bone implants, Sign manufactures over 30,000 intramedullary nails per year, in addition to plates and screws. And we do have a design that our engineering team is working on as far as a spine pedicle screw implant system. But right now, we've been very fortunate to have very generous grants from a number of the major manufacturers in the United States to assist in providing implants to use in the countries that we work with. So anyone that would be interested simply needs to, if they would just simply go to our website and contact us, we would love to entertain any thoughts they would have. We'd certainly love to have surgeons become involved if they're interested.
What does success look like 10 years from now? Where do you see Sign Spine Care going?
Well, I think in an ideal sense, one of the things that we're trying to be realistic about is a self-sustaining type program. So not only would you have a top-level spinal care, but you would have a network of institutions in multiple countries that would interact, and that would be in terms of data collection, publications, as well as presentations. So as you can imagine, the low and middle income countries provide a different environment that we have in either the United States or Western Europe. So we really try to focus on their needs and their capabilities, on the tools that they have to work with. But I think if and what we're striving for is a self-sustaining component to this. We're hoping, and we've actually done this with complex pelvic fractures in Addis Ababa, Ethiopia. We've had surgeons go from train in Canada, return back, and actually start their own fellowships there in Ethiopia. So we're hoping that the institutions that we're working with now, when we try assist in training the surgeons in Canada, they'll go back and hopefully begin their own fellowships there in spine over time. Obviously, that's a little bit more complex endeavor, but we have to just kind of strive for that. So we feel like the continuous education process, in addition to having available implants for the poor who cannot afford those themselves, we provide those free of charge. And then having them develop their own programs so that they can teach and enlarge those in a fashion that will fit the needs of those countries is sort of the avenue we're looking at.
Yeah, and right now we are publishing are going to publish a Delphi study where we basically reached out to surgeons in Africa to basically see what their needs are and kind of rank what they are. And so we're still processing all the data, but by having that information, we hear it from the people in the field exactly what would benefit them the most.
If I could add one other thing that we've tried to do that's we feel is very helpful is to actually go in and purchase the implants that are available to the surgeons in the communities there at this time. So a lot of the implants that are available come from various other countries. They can be very low cost, and there's no way that from just simply looking at the implants you can determine their quality or their durability. So we've purchased those ourselves, brought those back, and through one of our core surgeons in her lab, have gone through the Instrom testing to determine which implants are viable, which implants can actually last, and which ones would be probably avoided. So that's, again, more data that should be published soon.
We look forward to all the amazing work that you will continue to do through your organization. Obviously, we have a great ability and gift to give back. And I want to make sure I acknowledge and give you guys the time also on this podcast to just talk about any inspiring story or an anecdote that you can share from a personal experience that could bring this all back into, again, why and part of the mission in serving?
Well, I think a little anecdote that I have it's and I like remembering it's not just us helping them, but I've also learned a lot. It's pretty amazing what the surgeons in these countries are able to do with some of the limited equipment and resources that they have. And I've been in the operating room with them a few times, and I've learned things, and I've actually incorporated some of the things I've learned into my own practice here. And so oftentimes in these types of initiatives, it seems like a one-way street, but it's really a two-way street. And I think I learn just as much as I teach.
And I would have to agree fully with David. I think one of the things that's impressed me the most are that the surgeons in these countries are extremely capable. They're extremely smart and hardworking individuals who simply need the opportunity. So they will do their very best with the skill set, whatever that is. So one of our thoughts is to try to simply ramp up their skill set, ramp up their knowledge capabilities, and that's why we've had such a focus on the fellowship training in Canada, which allows them the optimal opportunity to build their skill set, to understand how medicine's practiced in Western Europe and in the United States, and then take that skill set back. Once they have that, then they can tell us much better how we can be of assistance to them. So instead of trying to lay out protocols that they should follow, we ask them to see how things are done here and ask them to initiate protocols they feel would fit their systems most optimally. So it's really trying to, again, empower the surgeons, empower their teams, and empower the systems in these hospitals that just have not had that opportunity before.
That was such beautifully said for both of you. I tried my best to wrap up your article and hit some major points. In concluding remarks, is there anything else you'd like to add about the organization or the work you guys will continue to do?
I mean, we're thankful to everyone who collaborates with us and supports us, and anyone who's able to support us within their capability, that would be very welcome. Um, yeah, we look forward to continuing expanding and really making the world a better place.
Yeah, I would like to follow, if I could say in addition to that, our organization is made up in actuality of about 50% neurosurgeons, 50% orthopedic spine surgeons. So we would love to talk to any surgeon who has an interest or thinks that they might have an interest in the future and assisting in this pursuit. This is a growing organization. We're presently in 3 countries, Tanzania, Kenya, and Ethiopia. By the end of this year, we'll add Malawi. We're having a program starting in Pakistan. And then we expect to expand further. We should have a total of 10 programs by 2027. So it's a slow and steady growth. We would love to have the support and interest of surgeons who would like to participate.
As NAS continues to grow and the organization continues to grow, and social media and ability to get your article and your work more light, I do believe that we will be able to support uh, such an amazing cause. I think we're all so proud to have colleagues who are so dedicated in this country and across the globe to make sure that we can deliver the best care. And as you mentioned when we started, to everyone, because everyone deserves best quality care. So thank you both for your work in and out of the organization and across the globe. We really appreciate you joining us today.
Thank you for this
Thank
time
you.
and the opportunity.
I believe that wraps up the questions for today's podcast. Thank you again, Doctors Gendelberg and Dr. Coscia. Um, to all the listeners who tuned in, we really appreciate you. Thank you for joining us on our NAS Spineline podcast and tuning for all the amazing work that our colleagues continue to do.